You know,
Is it because
it was too sad. Too sad.
Yeah, it's too much movement. You want a little movement.
Yes.
You don't want to.
So that's why that ending went away, because ultimately people would leave the theater and they would go like, that made me feel sort of bad about stuff. But the ending that we went with, just to be clear, I mean, endings are very personal for people. Like some people, in that ending you just watched, some people left the theater and said, you're still kind of a jerk. You know what I mean? Like I would get very personal responses where people are like,
Yeah.
you're like an ungrateful dad, you're a bad dad, all this stuff. And I'm like, no, I'm being honest with my experience, and this is pretty close.
This is exactly what we're talking about, which is that endings carry massive, disproportionate weight. You don't go to a show or a movie or read a book and decide after the first 10 pages that you love it. That's it. I mean, you might say that, but it's a contingent conclusion. You will rescind that opinion in a heartbeat if the last 5 pages or the last 5 minutes don't work. And what's weird about this, of course, is that it's the opposite of the way we evaluate human beings. There's a famous set of studies about college professors where they take student evaluations of their teachers that are generated over an entire semester and compare them to teacher evaluations made by students who've only seen a tiny video clip of the professor, like 10 seconds. What do you find? That the two sets of evaluations are the same. In other words, you're sitting in a class, you listen to your teacher for the shortest moment, and you decide, I like them, I don't like them, and you never revisit that conclusion. The ending doesn't matter. If you have 30 classes with your history professor, your experience in the final class, or the final 5 classes, or even the final 29.99 classes does not alter your impression about the teacher. Our evaluations of other people are front-loaded. That's why, correctly, our parents told us again and again about the value of making a good first impression. But our evaluation of stories is the opposite. It's backloaded. What happens in the last 5 minutes colors every conclusion we drew in the first 2 hours. Now, why is this? I have no idea. But I will guarantee you that every screenwriter and author and podcaster frets endlessly about how their stories begin. Rewrites the beginning a million times, but aren't nearly as fastidious about the ending. Which is nuts. We're all idiots. With the exception, of course, of Mike Birbiglia. When we come back, endings, part 2. You know how they always say that children are natural language learners? That a 2-year-old can master French and English and Spanish all at once, effortlessly? It's true. But you know it's not true? That it's all but impossible to learn a new language once you aren't a child anymore. Nonsense. Our brains don't shut down once we become adults. That's what Rosetta Stone has proven. You want to go to Italy this summer and fool them into treating you like a local? Rosetta Stone has been the expert in language learning for 30 years. They've helped millions of people build the fluency and confidence to speak new languages. They know what really works when it comes to getting you started with a language, helping you remember what you've learned, and motivating you to stay on track. For a limited time, Revisionist History listeners can get Rosetta Stone's lifetime unlimited subscription, which gives you access to all 25 of their languages forever, for 40% off. Visit www.rosettastone.com/Gladwell today. Rosetta Stone, how language is learned. In this episode of Revisionist History, we're talking about the crisis in girls' sports. From chronic injuries to the pressure of getting into the best colleges, and most of all, parents. You have to know how hard it is to be a coach these days. With some crazy parent calling you at all hours or making a nuisance of themselves at games. If only you're a way to find and hire the perfect parent just for Saturday mornings. Someone who will sit quietly, say nice things about the referees, tell the coach afterwards, thank you, you know more about soccer than I ever will, and then chauffeur as many players as possible to the nearest pizza parlor. Are you listening, ZipRecruiter? Because you've solved every other hiring problem.
Hey, good morning, everybody.
Hey, good morning, everybody.
Morning, sir.
Hey, am I sharing my screen?
Am I sharing my screen?
Yes, we say case JH.
Case JH. All right, good.
All right, good.
I'm gonna try to do it from my computer in the office, sharing my computer in the office. I'm getting a bit of an echo though.
We also hear the echo. I don't think it's from our mic being on though, because we just had it off.
Yeah, I think there'll be less delay with the visuals. Is it flipping pretty quickly between slides?
Yes.
All right, we'll try it like this. Oh, hi, Lily. Okay. Yeah. Hi. Hey, good morning. How's everybody?
Good morning. How's everybody? Morning.
Now, can you guys hear an echo? You can hear my voice twice.
Yes, we do, but it's okay.
Yeah, I can't use the microphone in my office computer because it's trying to pick up what's in the office, and then it won't. You guys won't be able to hear me.
It's really not too bad. It's not quite like a double echo. It's just a little bit of a reverberation. I don't know. Okay. It's not too bad. We can hear you pretty well.
All right, I can hear you guys perfectly. All right, you guys want to start it up?
Let's do it.
All right. First case is JH. Chief complaint of right knee pain. This kid is a 17-year-old male. Comes in with his mom complaining of the right knee pain. Stiffness over the past few weeks. He had this injury for the last 2 weeks, but he had it a while ago when he twisted his knee playing volleyball. He thought it locked at that time. He was sent to physical therapy. They worked on him and he got better. About 3 weeks ago, he was standing up and he was unable to straighten it completely. That has since gotten better, but it's still catching and locking. He has pain now. It's 8 out of 10. Interestingly, he smokes THC oil that anesthesia was very nervous about, but I guess is becoming more and more common in our younger population. The on exam, his skin is clean, dry, and intact. No ecchymosis. His range of motion is actually pretty good. It goes from 0 to 130. But going from about 5 or 7 degrees to full extension, he's very hesitant about that. But I can do it. I can do it passively, and he gets there. He's stable to varus valgus, tender at the medial joint line. No pain or laxity with anterior drawer or Lockman. Posterior drawer is negative. He does have pain medially with McMurray's test, and his twisting. He says twisting motions are worse when he's active or when he's trying to play volleyball or sports or whatever. Distally, he's nervascularly intact. All right, these are his X-rays. Can someone read his X-rays?
We have a AP and a lateral of a left knee. On the AP, you can see some lightening of the lateral femoral as well as the it almost appears like a sclerotic border of the medial tibial plateau, and some loss of joint space on both sides. I think it's a 30-degree flexion view. And then the lateral, same thing, some mild sclerosis on the tibial plateau and loss of joint space. It is a little bit rotated, the view.
Yeah, I agree. The don't see any fractures. It does look subtly different. His condyle is a little wide, but that just may be him. All right, his MRI. We got an MRI because I was concerned about his intra-articular structures, and these are slices on the sagittal. Can someone read these? Another junior. First year.
Okay, so these are sagittal views of the knee. We'll start in the top left corner. So here we can see like the bow tie figure of the meniscus. There's a slight hyperdensity in the kind of like posterior area of the meniscus. Then moving on to the next.
You talking about right here?
Pardon?
Are you talking about right here? Can you guys see my cursor, my mouse?
No.
All right. Go ahead. Go on to the next one then.
Sorry, so moving on to the next one. So we're trying to see here if the ACL is intact. From that image, it looks like you can see full continuity of the ACL, so no, concern for ACL rupture. Then moving on to the next two images, so still sagittal images of, we can see your cursor now.
Oh, good.
Sagittal images of the knee. It looks like there is some swelling and fluid in the knee, and potentially again hyperdensity kind of in the posterior area of that meniscal bow tie that I was talking about before.
And that, did you do that? Was that the last one?
Yeah.
All right, so cool. Now that I have a cursor. So this first one, these are T2s, right? Your HTO is white. T2, H2O is white. And this is just through the medial meniscus. I just wanted to show you guys that there wasn't any big tears there. And you correctly identified that there's some signal here. But most likely in a 17-year-old, that's not going to be a tear. It's going to be a what? Vasculature. Yeah, exactly. And especially, this is actually not a bad image. We'll see later. This is where the red zone is, right? This is where we're going to have some vascularity. All right, so I put this slice in here to show you the ACL. When I was a resident, we couldn't see the ACL this well. So MRI technology is amazing now. And this ACL looks like it's intact. It's got some tension to it. And there's some signal around it, but it doesn't seem too bad. And then we're starting to get this little shadow here. And then now you can see this dark signal here. And this is classic for a meniscal tear. A bucket handle that's flipped into the notch. Now I know you guys can't scroll through, so it's hard to see which part of the knee this exactly is. But once you see the ACL, and then you see this structure line front to back, there's a good chance that that's a bucket handle. And then this image confirms it. So you said there was a bow tie over here, right? And where's the bow tie here? Where's the back part? So this is gone. And now it's sitting up here. And it's pushed over. This is the other part of the bow tie right here. So this is the classic bucket handle tear appearance. And the bucket is flipped into the notch. So burn this one into your brain. This is one that's often shown on boards. Alright, so what do you want to do with that? 17-year-old with a bucket handle tear.
So since he's a younger guy and he's quite active, he's symptomatic, I would want to bring him for probably a repair. I think he'd do better or do pretty well, especially because he'd be motivated to get back to mobilization pretty quickly after the surgery.
What are we worried about? So another junior. Or another first year? What are we worried about in his history?
Well, I mean, when you ask about what we'd like to do, he already had failed therapy one go around, so we know that conservative therapy might not be good for him. He does have a history of the THC smoking. I don't know if that may affect the meniscal healing, but otherwise, that was everything I kind of put with history that was important as far as operative considerations.
Yeah, that's a good point. He failed therapy already. And we are worried about the whatever smoking. We don't have great data on that. But we know it's probably not good.
He's got a lot of instability when he's active.
Instability when he's active. And also the fact that the initial injury was 2 years ago. So we want this to heal. There's a chance that that was torn from wherever it is. Hopefully it's a repairable part of his meniscus in the red area, which we'll go over. But we want that to be able to grow blood vessels across the gap. And if he's had 2 years of this meniscus being torn in that area, and that may decrease our chances of that. So the chronicity of his injury and the and other patient history factors, which for him is just the big thing. All right, cool. Any questions about that? So we took him to the OR, and unfortunately, it was his right knee. So this upper left box is a picture inside his medial compartment, right? Because his right knee is facing you. Here's his meniscus. My probe is underneath it, and I'm pulling on it, and his medial meniscus seems fine. Now, unfortunately, I reduced his lateral meniscus before I got a picture of it. So this is his lateral meniscus, and it was sitting in, blocking the camera, and now it's pushed back in where it belongs. And in picture 7, you can see there's a all inside suture technique. I think this is a fiber stitch. There's a couple of them there, and there's another one over here, I think. So I used 3. I probably could have used more. In retrospect, I always wish I put in more. But we used an all inside technique to repair this guy's meniscus. He's at about 6. I think I did this in October, November. And his last visit he was back to starting to go back to volleyball, whatever. And so we'll see. Hopefully this will heal uneventfully. But it's definitely worth it for him. All right, so the meniscus. So we could talk about OCDs and stuff, but we'll focus mostly on the meniscus for today. You can see this image behind. There's a repair technique for this is also this is a medial meniscus repair. These are little anchors, and this suture was one that you tied, and you linked these anchors together. That was an older technique. Now I like the all suture technique with the fiber stitch, but there are different types of all inside, and we'll see. There's multiple kinds of meniscus repair kits. All right, introduction. You have to do a little basic science. We already talked about clinical evaluation, treatment options, and then meniscectomy is the most common thing we do. Meniscus repair is the thing we want to do, and meniscus transplantation is something I never want to do. But that's one of the options as well for treatment. So here's our meniscus. And see how perfectly it aligns with the articular cartilage. This is something you can't see on the x-rays. The MRIs, the fluid in here kind of throws you off, but look how well that meniscus allows that joint to move. You know, that cartilage just slides right across that meniscus perfectly. And here's our vascularity from, this is still a classic picture from Orthopedic. This is the 3 zones. And you see the white. There's not even like spicules. There's not, so when we have little tears here, they're not going to heal, right? If we try to fix them. So here is our transition zone, our red-white. You can see little spicules of this is ink. I think this is ink or plastic. I forget how they made this image. But you can see this is different than this. Right? So we have a chance. And then here, this is where his tear was, that first patient. It was right about here. Can you guys see my my cursor, my red cursor?
Yes.
So this is where he is. So this is where we can grow blood vessels and heal. The red zone. All right, like the human body, the meniscus is 72% water, 22% collagen. But this is the dry stuff. This is the more interesting stuff, right? It's type 1 collagen. There's still some 2, 3, 5, 6, but most of it is type 1 collagen. Type 1 collagen is usually your answer. Unless they ask you about what cartilage. What's type 2? Nope. Articular cartilage, yeah. And the annulus, and the spine guys will ask you, the annulus is type 1, and the nucleus can be type 2. But most other things, bone is going to be type 1, and meniscus is type 1. And then you have these other amazing molecules, elastin, the proteoglycans, and the adhesive glycoproteins. And then the majority of the meniscus, the fibers are oriented which way? This is a good picture, and I have an even better picture. Most of them are circumferential. So if you're designing a shock absorber, you know, you could put just a bunch of, like a piece of cheese in there, and that would work a little bit, right? But when you have axial load, that's going to be transferred to a tension load. So the meniscus is designed to have more strength and tension along its C shape. And that's why when you repair it, you have to grab those bundles. You have to come around these cables and fix it. You can't just punch it in, punch a suture in here and then punch a suture here and hope it's gonna. You have to grab this whole bundle and attach it to the wall. This is, I think, electron microscope or light microscope. See, all these fibers are all longitudinal. They're all longitudinal, and they're designed to turn compression into tension. But that's why we have to grab those cables with your meniscus repair. Now, motion. Which meniscus moves more, the medial or the lateral? Lateral, right? Yeah, you'll see that when we do arthroscopy. We grab the lateral meniscus and we pull on it, and it always moves a ton more than the medial side. The medial side is pretty adherent. And this is a classic study. This is with flexion and extension. And you see with flexion, the meniscus moves posteriorly. This is medial, this is lateral. And the medial side moves only 5 millimeters, and the lateral moves almost a centimeter, or over a centimeter. So that's obvious when we do an arthroscopy. You can really pull the lateral meniscus away from the tendon on the lateral side that you can see. Do you guys know that? Have you seen that during arthroscopy? What's that tendon we see on the lateral side? Popliteus. Yes. We call that. I always call it popliteus. But I guess the New York pronunciation is popliteus. There was a guy in D.C. that would call it popliteus too. But you can call it either way. Alright, so just quick review. Collagen type, mostly type 1. Oh, this is a good one they'll ask too. Ligaments attached. transverse intermeniscal, that's in the front, and your meniscofemoral, which are what? Who is that? Humphrey and Risberg, yes. Which one's in the front? Right. Now blood supply, I have a good slide on this during our questions, because this is something that will be kind of confusing. So most of the outer rim of the meniscus is from the inferior geniculate, medial and lateral. But the roots are from the artery that also feeds the ACL and the PCL. And which one is that? The middle. Yes. So you have to pay attention to how they're asking this question. But they love that one. Stabilizer to anterior translation. Posterior horn of the medial meniscus is a secondary stabilizer. That lateral meniscus is too mobile, so it doesn't give as much. But the posterior horn of the medial meniscus is the next one after your ligamentous structures. And the most common indication for knee surgery is the meniscal tears. So if you guys give up arthroscopy and become joint specialists or spine guys or whatever, just remember you're giving up the bread and butter of your field that has done so well for you thus far. All right, functions of the meniscus. Load transmission we talked about. Shock absorption we talked about. Joint congruency we could see on that first slide, right? Stability of the knee, we talked about that. Posterior horn of the medial meniscus. Joint nutrition and lubrication is a small part of it. And proprioception is probably a more important part than we realize. And this is just a slide showing that posterior horn of the medial meniscus. So they did translation studies, and they did took out the meniscus and the ACL. That's your top line. So the knee is slopping all over the place. If you take out the ACL, it's still pretty sloppy, but this difference is significant, right? This is our meniscus that's helping with this. Down here, the ACL is still intact. So if the ACL is intact, your meniscus is still providing some stability, but it's really the ACL deficient knee where we realize how significant that stability is. And this study showed another 5-6 millimeters difference. On the right side you can see the ACL is intact, and here the ACL is torn and the translation is a lot more. But this is what beats up the meniscus, right? And people come to us with symptoms of that. This is that picture from when we talked about the chapter. You just always have to remind yourself. Humphrey's in the front. This is a view in the back. The green is the PCL. And this is Risberg. And this is Humphrey. And they're attaching to the lateral meniscus. Unfortunately, on boards, they don't always give you that many slices of the MRI. So you just kind of have to remember. So here's right near your ACL, right near your PCL, on the front and back of your PCL. Here's your Risberg, and here's your Humphrey. All right, so do anyone know what Fairbanks changes are? So my first edition of an ortho textbook was I had an older Campbell's, and it still had open, complete meniscectomy as a procedure in it. So when the meniscus was painful, people would take it out and have less pain. That led rapidly to arthritis in the area where they took the meniscus out. So this was a complete meniscectomy, and you developed a ridge, flattening, joint space narrowing, and they were called Fairbanks changes. And this was, within 5 years, within 3 years of the complete meniscectomy. So Fairbanks published this, and that's why we don't do that anymore. And then we wiped it out from the literature as much as we can. But it was helpful to show us how important the meniscus is. Now do clinical presentations similar to our patient. Twisting mechanism, pain, swelling. Catching and locking are going to be the key. Catching and locking, you have to have mechanical symptoms from this knee, because every other patient I see is an older guy like me, 50-some. He's got some meniscus catching and locking symptoms. He's got some joint pain that's a soreness or a toothache. And somebody got an MRI, and the MRI shows a small meniscus tear. And so you have to figure out whether that small meniscus tear is giving your patient the symptoms, or whether it's just early arthritis. That's really the key. And so you want to focus on the mechanical symptoms. The more mechanical the symptoms, the more likely it is your meniscus. And the more soreness or toothache, then the more likely it is your arthritis. Alright, so surgical treatments. We've talked about these. And there's really a push now to save the meniscus, which is good. It's good for us in the sports side of orthopedics, but it's good for everybody. So be more liberal with your indications for trying to fix the meniscus. We talked about meniscectomy. This is still the #1 procedure. And then transplant. I haven't seen one of these in a while. This is, when I was in the military, even it was rare. But that was somebody who, they're 21 and their meniscus is completely shredded, and a transplant might be the only option. Usually we have to do that with bone blocks. And then there's also a trend now a little bit back towards osteotomies. I just included this. This isn't a common thing, but either for a transplant or for a difficult repair, somebody who has a coronal plane malalignment, it'll be hard to transplant or repair a meniscus in the area that's going to have all the stress of your knee, right? Somebody's in varus, and then in the medial side you're doing a complicated meniscus repair, so there is a movement towards doing a high tibial osteotomy. This would be an opening wedge or a closing wedge, but somehow to take some of the weight bearing away from the side where you're putting the meniscus in to another part of the knee. Has anybody in the room seen a high tibial osteotomy? Yeah, was there somebody? Yeah. Yeah, Dr. Krawicki still did a fair number of them. Like when I first arrived here about 13 years ago. Alright, so here's a partial meniscectomy. We just take out the torn parts and smooth it to a stable rim. So even though this looks like a big piece, when you pull it out it's a big piece, you're still leaving the knee, all of this normal meniscus here, you're still leaving all of the, I tell the patients that the meniscus looks like kind of like a stadium, and here's near the side, these are sideline tickets, up here is the cheap seats, but this is really the most volume of your meniscus. So even when you take out a small tear, this seems pretty big, this tear seems pretty big, but you're still leaving them all the middle, all the club level seats, all the cheap seats, And all the structure behind that stadium, you're still leaving in their knee. So partial medial meniscectomy, partial lateral meniscectomy. Again, we have to have our indications. They must be clear. And has anyone read any sham studies on meniscectomy?
Yeah.
And what did it show?
Like really no difference.
No difference. So what are we doing? We're just costing the healthcare system a ton of money. Eventually, they're going to crack down, and I'm going to be on the street, telling people I'll scope for cash.
That's why you do Georgia Spine.
That's why you stay general. You can always adapt. But these studies are fantastic studies for us to remember. And most of them have shown that it's really the mechanical symptoms that were ignored. And a lot of these are degenerative meniscus tears in people that have early arthritis. And the MRI is overcalling all of these. So that's why you have to align your exam with the medial compartment, align your exam with your McMurray, align your patients with the mechanical symptoms, and you can't operate on everybody that has knee pain and an MRI positive for a meniscus tear. But these are good. There was one before my residence, so there was this is the most recent one that I thought was cool, New England Journal of Medicine. But it's very, very interesting. And the sham surgery, we'd love to have that for everything, right? But what's the problem with the sham surgery? Right, almost all the risks of surgery, and potentially no benefit. And then you always have to figure out how far do you go. Like the spine literature, they need a sham surgery, right? They need to prove that taking out this part of the nucleus pulposus or taking out this part of the herniated disc really caused help. But for their surgery, by the time you dissect it down to that area, it'd be hard to just look at that piece of disc and then leave it there, right? But that'd be the only way to keep those populations similar. With arthroscopy, when you read these studies, you'll notice they made the portals and they flushed some saline through. So it's almost a similar intervention between the sham limb and the meniscectomy limb. So it's really it's ripe, and they're very interesting studies, and they're humbling, and we have to always remember them. Now, meniscus repairs. What types of meniscus repairs are there? All inside. Inside out. And what else? Outside in. Yeah, and I like using the outside in technique with a difficult repair. I haven't done it in a while. But it allows you to hold the meniscus in a good position even for your all inside, because the all inside techniques are a little the equipment's a little delicate. So this is the way we used to do it when I started residency. This is an inside out, and we had these double-armed sutures with these long needles. They were about maybe 6 inches long, and you would get a retractor on the outside of the medial or lateral side, and then you would fire these long needles through these cannulas that were curved, and you could find a spot wherever you could angle it here, and then you'd slide the needle through, and you would put it all the way through their meniscus, through the capsule, and then outside of the knee, and then you'd fire one limb here one limb here, and then your attending would be yelling at you, asking you if you could see it, and you could say, I don't see it, and they'd say, why can't you see it? I'd say, I don't know, I don't see it. But the nice thing is that would, then you would tie on the outside, and you could place the meniscus, the suture repair wherever you wanted, which was nice. And see the way they're demonstrating this, like all those cables are here, right? They're trying to bind all these cables. This isn't as good. This is a nice suture placement. We have a lot of the cables, right? These are longitudinal cables. We grab them all here and here. And these are these end up vertical. When you look on this side, they're vertical suture. And this is your inside out. Inside out, now you're piercing through the skin. You're coming through the meniscus. And you have different needles. One will have a loop, one will just have the needle. And then you pass the suture, grab it in the loop, also tie it on the outside. And here they're showing a horizontal, right? So if that's in between the cables, that's not going to be as good. It's still good, but it's not going to be as good, right? So you always want to make them a little bit oblique when you can. And remind me when we're doing a meniscus repair, because we can get these. They're a set of pink needles. TFCC, Dr. Culp uses it the same. All right, and now this is another way to do it is using bone. This is for a root. Arthrex has kits for this. I have not used this kit yet, but I'm planning next root repair. I'm going to do it. And then most of the time we're doing all inside. All inside is pretty much taken over. But remember this. Remember this picture from our chapter 40 review. That popliteal artery, it's right behind the posterior horn of the lateral meniscus, right? So depending on where you stick your needle in, here's your portal. You can go through the meniscus and you can hit the artery. You can go from the portal through the meniscus and hit the artery. We don't want to do that. 1936, healing of semilunar cartilage. These are just one of the reference. Here's a nice image where they show the blood vessels. They have to come across to fix this, and they did in this image. And discoid meniscus, just to be complete about the meniscus. The discoid meniscus did not develop into the semilunar cartilage. It just developed into a flap, and we think because of that, it's more likely to tear. So here's, or give you symptoms. Here's your discoid meniscus. And how do you diagnose the discoid meniscus on MRI? Right, 3 views of the bow tie, but you can see the knot. You can see the middle part in all of them. All right, any questions? We have a couple questions, and I'll let you guys go. All right, somebody read this one.
Figure 1 shows a sagittal oblique MRI scan. The arrow is pointing to what structure? It's going to be I know we're looking at the posterior side. I'm not sure if it wants us to talk about one of those anterior ligaments that's close to the PCL, but if it is, then we'll try number 3. 2.
2. Yes, it's in the front. Right? The Humphrey's in the front, they go alphabetical. Risberg's in the back. And then somebody do this one. I have some good pictures for the vascularity question. So someone do this question quickly.
A 16-year-old boy sustained a twisting injury to the left knee while wrestling. MRI scans are shown for years. See what is the most likely diagnosis. So I think I see a double PCL sign.
Double PCL, exactly, right here. That's that meniscus flipped into the middle. Here's the PCL. Here's the meniscus flipped in. So what are you going to go with? 3, right? Bucket handle, medial meniscus tear. All right, here's the image I want to show you. Posterior horn of the medial meniscus receives its primary blood supply from what artery?
Is it
One, middle genicular, yes. This is one that they're going to try to trick you up on. Your ACL, your PCL, and your posterior horn of the menisci, that's your middle genicular. Here's a good picture. This is in the back. You have the two top, superior, medial, and lateral, inferior, medial, and lateral. And then most of the time this is drawn as coming off the front and going a little bit more to the medial side than it's shown here, but this is gonna capture your ACL, your PCL, and your horns. And then just looking at this image, for the outside of the meniscus, that's going to be attached, you know, because your knee bends, right? So these arteries are going to stay with your tibia. Your meniscus is closer to sitting on the tibia. You know, it doesn't sit on the femur, right? So that's where you get the blood supply for the outer third of the menisci. Here's your middle geniculate coming in, ACL, PCL. Here he is coming into the medial side. And then here's a good picture. The posterior horns and the menisci, they're getting middle geniculate, but this pink area in your meniscus where we want the healing to happen, this is going to be medial inferior and lateral inferior geniculate. Cool. All right. And my recommendation is for this week is 2 comics that I like. Sometimes you need to relax. So there's a Walking Dead comic now that where this used to be black and white, now they're colorized. It's amazing. It's a great story. And this artist on Daredevil is a guy named Marco Cicchetto. He's amazing, and sometimes you just need to read something that's completely away from what you have. So don't forget to do that. All right, guys. See you at Morning Report.
Thank you.
You're welcome.